the clear outline of the growth plate on the lateral aspect. But as we are coming here medially, we see that there is irregularity along the growth plate and there is widening. So there is separation which is happening here. So separation means the first stage in a pediatric trauma is a Salter and Harris injury, where we see is separation of the growth plate. And so this falls under type 1. If it would have gone above, that would be type 2, and if it's below, it's type 3. Okay, so now what is happening is that there is effusion, there is fluid buildup here in the within the growth plate on the medial aspect. There is irregularity along the physis, the margin here, and what we are able to see here is an L shape, a reverse hockey stick shape structure here. What this is, and many of you have answered this correctly, this is the trapped periosteum, and the periosteum here has stripped away and invaded inside the growth plate. So this is a case of Salter-Harris type 1 injury with trapped periosteum. So whenever you see such injuries, always look at the the periosteum, that it's not stripped up, what is the status, and make sure you mention in the report. The meniscus here, the meniscus on the lateral and the medial side, they look good, and the ligaments are not completely shown in these images, but the idea was to look at the periosteum here. Next is a 12-year-old soccer player complaining of hip and thigh pain after a match. There is tenderness in the left gluteal region. There is radiating pain, and X-ray was reported normal. So please share your views on this radiograph. What do you feel where the pathology is and what it could be? Nice answers coming up. Why are we thinking of PVNS on X-ray? Simple things, please. History is that he has got sudden onset left-sided gluteal pain after a football match. Okay, so this is a frontal radiograph of pelvis with both hips. Again, a skeletally immature patient. The growth plates haven't fused as yet. The irregularity along the iliac blades, these are the normal apophyseal appearances. Okay, this is not pathological. Secondly, as you come down, you see some sort of sclerosis along the acetabular aspect, okay, of the hip joints. This is again normally seen in pediatric age group. Okay, now as you come down, you see all the bones from right, left, and center. I think a few more answers are coming up. Good. Okay, so as you go, always try to look at various apophyses. Apophyses are the areas where there is a tendinous attachment, the muscles attach to these bones, and these are soft bones in pediatric age groups. So with subtle injury, with mild injury, there is traction over these structures, and hence there can be bony avulsions. So this iliac blade, the upper part is the attachments for the side oblique muscles of the abdominal wall. The anterior superior iliac spine has attachment to the sartorius. The anterior inferior iliac spine has attachment to the rectus femoris. The greater trochanter has attachment to the gluteus medius and minimus. The ischial tuberosity has attachment to the hamstrings. Okay, while the pubic symphysis has attachment to the rectus abdominis. So here what we are seeing on the left side, as we know the pathology is, we see some fragmentation, some irregularity, cortical irregularity in the ischial tuberosity on the left side. And many of you have answered it very correctly that this could be an avulsion injury. Uh, but from where? So it's from the hamstring tendon. So this is the normal hamstring tendon which is attaching to the ischial tuberosity. While on the left hand side, we can see that there is marrow edema, extensive soft tissue edema, and the good thing is that the hamstring tendon hasn't retracted. So there is an avulsion fracture. With the fragment here, there is fracture here, and it is in flush with the parent bone. It hasn't retracted inferiorly. Okay, and this appearance, this bright appearance here is nothing but red marrow. This you can see in the sacrum also. Do not confuse this bright signal which we see in pediatric age group with bone marrow edema. Always compare it with T1 weighted images to rule out whether there is marrow edema or not. So this is a case where we can see that avulsion injury of left hamstring tendon, and there is extensive soft tissue edema which is tracking along the left sciatic nerve. So this is the picture which is showing the various attachments to the apophysis which I have discussed. Similarly, this is the next case where it's a companion case where there is avulsion injury of the gluteus medius on the greater tuberosity. Okay, so this is the gluteus medius tendon attaching to the greater trochanter here, and there is discrete tear here at the attachment site and lot of soft tissue edema in the peritendinous region. So these are the common sites of avulsion. Always look at all these sites on the radiograph whenever it comes to you. Okay, so 8-year-old kid with knee and foot pain since 3 months. No fever, limp present. There's elevated ESR and CRP is elevated. So these are the two images which I mentioned showing you. Please free feel to answer. What could this be? Good answers from all of you, those who have answered. Request more participation. So we have different answers coming up, like JIA, which is juvenile idiopathic arthritis, osteomyelitis, subperiosteal bleed, periostitis, osteodosteoma, muscle edema along vesti, scurvy, biceps femoris edema, osteomyelitis, Reiter's arthritis with bone marrow infarct, early changes, osteosarcoma, Codman's, rule out non-accidental injuries, Fope zones, inflammatory arthritis. Good. Happy. You will enjoy this case. So these are the MRI coronal fat suppressed images of the knee joint. Again, skeletally immature. The growth plate is well seen. Okay. Here we are able to see difference between this hyperintensity as well as this hyperintensity. Okay. So there is difference between this bright signal and bright signal in the distal femur, correct? As you compare it with T1 weighted images, this dark appearance on T1 weighted images is more than what we see here in the tibia, correct? Okay, any doubts? Let's go further. There is edema in the surrounding soft tissues in vastus medialis muscle, okay? And because he also had pain in the leg region, there are some images from the leg MRI also. If you want to alter your answers, you can. If you wish to add more, I'll be happy. Similarly, what we are seeing here is flame-shaped pattern of marrow edema. As we see here, it's like a flame-shaped, broad-based pattern of marrow edema in the metaphyseal region, extending in the diaphysis. Okay. And here also we see the same pattern in the fibula. There is a flame-shaped pattern of marrow edema in the metaphyseal region, in the distal tibia, and there are multiple bones which are involved. The metatarsals, the calcaneum, the talus. Good response now. Yes, you all got it right now. So now people are saying CNO, CRMO. Good. Okay. So this is a case of chronic non-bacterial osteitis called as CRMO or chronic or CNO in abbreviation, where we see that there is a flame-shaped pattern of bone marrow edema, and along with that, there are multiple bone involvement. Okay. I would like to discuss role of whole body MRI. So in cases of suspected CNOs, once they have a clinical history, the clinician, the pediatrician may ask for a whole body MRI, and where we could see that there is some flame-shaped marrow edema in the distal tibia here, above the in the metaphyseal region, and the rest of the tibia looks bang good. Here in the knee joint, we see no other pathology. Okay, the femur looks absolutely good. Okay, there is mild effusion in the right hip joint, which is little more than the right side. Okay, no marrow signal abnormality seen in the pelvic bones. But as you come towards the SI joints, try and see that there is an evidence of sacroiliitis on both sides. Okay, there is marrow edema here and on both the sides, lesser on the left, more on the right hand side. And humerus again looks fine. Uh, the radius and ulna looks fine, no abnormal signal. Clavicles are again common areas which are affected, but we don't see any pattern of marrow edema here. And the cervical spine, whatever marrow we are seeing, looks okay. So along with this coronal stir whole body, we need to have T1 weighted images where we can identify patterns of marrow edema, and in one image, in one scan, we can identify if there are multiple areas involved or not. So in this case, this was the area which was dedicatedly scanned here, which I have images of. So we could see that there is sacroiliitis on both sides, mild right sacroiliac joint effusion, okay, and rest of the pelvic bones, the femoral heads, the trochanters, the pubic bone, the ischial tuberosity, everything looks perfect. The visualized vertebral bodies are fine. So this was an idea of showing you how whole body MRIs can also identify multiple pathologies, multiple sites. So there's another case which I had recently encountered with a pediatric rheumatologist. And so this was a case of CNO with vertebral end plate fracture. And this was new to me actually, but I again happened to discuss in one of the conferences with pediatric rheumat again, and he said that it could have even involved multiple levels. So for this child, unfortunately, they did a PET scan after the MRI. So this patient had a single vertebral end plate fracture. Uh, just out of nowhere, one fine day, she had pain, and uh, this one. An MRI was done for the hips, the SI joint, and the lumbar region. And SI joints were fine. There was just one area of bone marrow edema in this vertebral body with a thin end plate fracture. Okay, and so this was the only image which I could get, and I could see there was a subtle marrow edema on the right acetabulum region on the right hand side, but there were no hip images. And this patient had come again for an opinion. So they had a PET CT available, which showed that there was PET, the tracer uptake here along the end plate, as well as in the right acetabulum. And the SI joints were normal in this case. Rest of the bones were fine. The right-sided acetabulum showed some marrow edema, and these were corresponding PET images which we could see. And yes, there was some tracer here as well in the distal ulna on the distal radius and ulna on the right side. It wasn't there on the left. And these were the clinical notes from the doctor where she had a clinical query of CNO, and she started with biologicals, and the child is doing exceptionally well with etanercept. And this is a case report which mentioned that there are contiguous 3-level vertebral level collapse in thoracic region in a case of CRMO. So always try to discuss, rule out these things, because this is not just a spotter image which could lead, which you will give as a diagnosis. There can be many causes to this, but it has to be given in a given clinical setting. Next is a 7-year-old boy with right-sided hip pain and pain relief with NSAIDs, no night symptoms, no history of trauma, and occasional limp. These are the radiographs, the pelvic radiograph of this child, and I would like you to give an answer to this. Think before you answer. Do not give vague answers, please. Just think which area you are looking at and what could be the possible diagnosis. We see a discrete lesion in the right femur. Okay, so because we're short of time and I have 2, 3 more cases to show, so I'll go a little quick. So we have we have a well-defined lucent lesion in the right femoral epiphysis, and there's not much of bone destruction which I see in the adjoining areas. Okay, and on focusing well, we could see that there are tiny specks of calcification within, which describes it to be a chondroid lesion. Okay, so what next? We did an MRI for this patient and we could see a T2 hyperintense lesion with central dark focus and a lot of marrow edema in the femoral head and neck region. Okay, an epiphyseal lesion which gives you a florid edema with calcification on X-rays. Think of chondroblastoma. These are very common lesions and can be managed with uh, techniques like microwave and radiofrequency ablation. In bigger lesions, they have to be excised and grafting has to be performed. And on post-contrast images, they enhance avidly. So this is a case of right epiphyseal femoral chondroblastoma. So lucent lesion with ring and arc calcification, florid edema, and intense enhancement on post-GAD images. This was a nice case which I again saw a few days back. And this child had syndactyly. I had not seen this in time before, and I had to seek help from my friend as well. So I thought of showing this case to you all. So this patient had a left index finger deformity and had syndactyly in the past, for which the release was performed in Germany, and now he's come up with an MCP joint deformity. So this was the preoperative image for this child. And later on, there was syndactyly in the little and the fourth finger. And after release, he has separated it, but now he has deformity in the second metacarpophalangeal joint level. And what do you see here? I've shown the X-ray here. I know someone will definitely hit the diagnosis here. So here we are seeing on the frontal radiograph a bone, an elongated bone arising from the epiphysis of the proximal phalanx of second digit. Okay, and it's going towards the third metacarpal. So someone says accessory metacarpal, Trevor's disease, pseudoarthrosis, carpal boss. Okay, let's go ahead. This was a little different, tricky for me. These are the further X-rays. On the right side, we see that the normal alignment is maintained. No accessory, no abnormal angulation or projection coming from any of the bones. And so this looks like a triangle, right? So this is labeled as a triangular bone. Okay, a triangular epiphysis. Okay, and this has been labeled as a longitudinal epiphyseal bracket. So this is the thumb. As I'm going from radial to medial side, we can see that the metacarpal is normal in signal intensity, while we see an elongated triangular shaped projection coming arising from the epiphysis of the proximal phalanx. Okay, And this is called a delta phalanx or triangular bone or longitudinal bracket epiphysis. And early detection helps to prevent deformity correction, because what happens is when there is loss of alignment between these bones, the metacarpal head tends to impinge over the flexor tendon as well as the volar plate at this level. Okay, so this needs surgical correction, and this child was taken up for a surgical correction by the wrist surgeon. Next is a 12-year-old with left knee pain. I think I just have one more case to show. This is an interesting case. I would like you to please hold and give your opinions on this. This will really change. Uh, it changed my thought process as well. So this will be of help. 12-year-old girl with left knee pain, more so after exertion. Pain started after playing, no fever, redness, or joint swelling. This was her initial X-ray in 24th in March 2023, which looked normal on the first appearance. This is the growth plate, normal in outline, but as you come towards the medial side, what you see is some widening in the region of growth plate and some soft tissue edema. I hope all of you agree. Okay, this is the second X-ray from 8th of April 2023, which the clinician had marked with the pen, and he thought that there is some lesion out here in the metaphyseal region. Okay, I'll show. So he thought that there is infection in this region and query Brody's abscess, and he did a bone curettage biopsy done, and biopsy yielded nothing, and just said that biopsy contained tiny fragments of bone tissue with fibroblastic like cells, no mitosis, necrosis, and nothing. He said correlate with radiology findings. MRI was done previous to the biopsy, and there was a lot of marrow edema on the medial aspect here, a lot of subperiosteal soft tissue edema in the muscles. Okay. These are the subsequent images which I see here. Some irregularity along the growth plate and soft tissue edema. These are the T1 weighted images where we can again see some abnormal signal here along the growth plate on T1. Anyone wants to give your views, you can feel free to write it here in the chat box. I'll give you 15 to 30 seconds. What all can be the possibilities in such a case? These are subsequent images, sagittal sections. So remember, there's no trauma. Surprisingly, even after a negative biopsy, the site from where the clinician had thought we see no lesion here on the fat sat images, nor on the T1 weighted images. There is no lesion here, which they had actually biopsied. That is why we could get just the bony trabeculae on histopath. Someone said osteomyelitis, physeal bar, eosinophilic granuloma. But this is a diffuse disease which we are seeing. Osteomyelitis, subacute osteomyelitis, JIA. Good, you're thinking. Okay. So unfortunately, this patient was started up with, uh, he was started on anti-tubercular therapy for around 9 months, I think 9 to 10 months, which I remember. These are the post-contrast images where we could see a lot of enhancement in the surrounding soft tissues and in the bone marrow, but no discrete discernible lesion which we are seeing. Okay, so minimal improvement with pain. The symptoms persisted even after the ATT was given for 9 months. And this X-ray was done in July 2023. Again, the clinician again thought that there is something in this region despite biopsying, and obviously that there is some erosion along the medial cortex of the femoral condyle. Okay, so MRI was repeated in Jan 2024 while the patient was on ATT. And these are the images now what we are seeing. Again, any changes to your answers? Yeah, so someone got the answer right. So there was a small nidus sitting here along the growth plate. Okay, this dark area here surrounding by bright signal. This was a periphyseal osteoid which was creating a lot of inflammation around this, causing growth plate irregularity, edema in the surrounding tissue. Okay, and despite that, the orthopedician wasn't agreeing that this is an osteoid and we finally got a CT cut for this, and we showed him the nidus that this is an osteoid. And now, if I come retrospectively to the first image, the first scan which happened before the biopsy, we could see a small nidus here which was osteoid, and the child unnecessarily took ATT for so many months, almost a year. So this was a periphyseal nidus along the distal femoral growth plate, and CT helped confirm the location and presence of osteoid, though the MRI, we clinched this on MRI again, and another friend of mine, she also did. And periphyseal location is a rare location. So disproportionate bone marrow edema in a non-traumatic setting, always rule out osteoid, whether it's a spine or any bone. This patient had history of night pain when repeatedly asked, and he said yes, the nights were the worst time. And she got relief with NSAIDs again. So last case for the day, 4-year-old child with left mid back swelling. Okay, and this was the ultrasound appearance. We could see a solid cystic lesion with echoes, some hemorrhagic content, and a lot of vascularity within the lesion. Okay, and what happened is that they went to a local surgeon, they got it just excised without thinking of what this could be. And MRI was performed, which showed T1 ISO2 hyper, T2 heterogeneously hyperintense solid cystic lesion, okay, which showed extensive post-contrast enhancement with non-enhancing cystic areas. Okay, and this was just excised without thinking of what this could be. And the initial FNAC was done, which is some vascular malformation, and the child had a big scar here. But the swelling started coming back again. And when the histopath was reviewed, it came out to be a dermatofibrosarcoma protuberance. So always think of lesions which involving the skin, the subcutaneous fat, which are enhancing lesions, vascular lesions on ultrasound. These can be sarcomatous lesions involving the skin and the skin adnexal pathologies. So imaging is required prior to the excision. Proper discussion with the radiologist is required because the surgeon has to be aware of the nature of the lesion, and margins should be kept free because there is high chance of recurrence in such cases. So this was a case of dermatofibrosarcoma protuberance, and I would thank you all of you for being so much patient listening to all these cases. And I would like to discuss that adequate history is important. Talk to the patient and clinician. At times we are busy in our practice with a lot of cases to read, but do discuss, gather what all investigations you have uh, from the patient, either do as a correlation part, ultrasound, X-ray, CT, and the role of STIR and T1 cannot be underemphasized in pediatric imaging. Should you have any questions and discussions, you can write down to me on this email address because we are already short of time. I mean, I thank you all for your kind attention.
You can have a quick look at the Q&A once.
Yes. Ankita, I don't see a Q&A page.
In your top bar, there'll be a Q&A.
Oh, yes, thank you. Difference between stress reaction and stress fracture? Nothing. So stress reaction is a preliminary stage before a fracture occurs. The fracture, you see a discrete break in the cortex, while stress reaction is that the bone is bearing the brunt. It's getting stressed, but it hasn't broken as yet. Okay, so stress reaction means edema in the acute phase, as well as there will be sclerosis because of the overall, the super added beating it is getting. Lymphatic malformation has blood fluid levels, can be seen. So these days we don't call it as lymphangioma, we call it as venolymphatic malformation. Uh, this is one question. Would you explain trapped periosteum again? Yes, I will. The apophyses are areas where we have cartilage and the bone. So the cartilaginous areas and the bone areas have a junction which gives the apophysis an irregular appearance. Okay. The rectus femoris origin was intact in that X-ray. It was just the hamstring because we have confirmed it with MRI. A protocol for whole body scan, we usually to stir coronal from different areas and then stitch those images together to form one whole body. And along with that, take T1 and axial T2 fat sat wherever required in the areas where we see abnormal signal. Can soft tissue edema be seen in CRMO? Yes, it can be seen. Whenever there is bone marrow edema, the cortex is getting loaded by the edema inside, there can be subperiosteal edema. Is a case of chronic backache in young female child with radiating pain to right leg. No disc findings. Only positive findings is right sacroiliac joint edema. Can it be seronegative? Yes, there can be seronegative spondyloarthropathy, but it has to be carefully watched that we are not saying red marrow as marrow edema. Always rule out red marrow can be confused with marrow edema. So T1 weighted images have to be seen along with the stir images. Okay. Sclerosis can be seen in chondrosarcoma, but not seen. Sclerosis is not seen. Usually we see tiny foci of calcification. Yes, so chondroblastoma and trapped periosteum I will show. Avulsion sites I will show again. TB and CNO in that spine case. TB doesn't cause, so this patient had a clinical suspicion of CNO actually. So there's a question how to differentiate TB with CNO in the spine case. So I had also never seen a case of CNO with spine fracture, but off late in one of the rheumat conferences, I happened to see this kind of a spectrum with from one of the rheumatologists. So they have also attributed to. So it says that there is end plate inflammation, and when the inflammation increases, there is depression of the end plate, and hence there is linear fracture which comes up. Okay, so I will come back to the slides again where they have asked me to show the sites for apophyseal. But this is the chondroblastoma X-ray someone has asked. So this is a lucent lesion here, lytic lesion here, with tiny focus of calcification. If you can just make out tiny specks here, I've tried to zoom in here. Okay, so epiphyseal lesion, lytic lesion, epiphysis location. Showing so the first possibility is a chondroblastoma. Okay, so then next thing which you have asked for is the avulsion fracture images. So these are the sites for avulsion injuries. So these are soft areas in a young child. So the iliac crest is for the abdominal muscles. This is for sartorius and tensor fascia lata. The AIIS or anterior inferior iliac spine is for rectus femoris. This is greater trochanteric for the gluteus, and this is for the iliopsoas, and ischial tuberosity is for hamstrings, and the pubic bone for the rectus. The above is the rectus abdominis, and lower down you come is the adductor longus. So these are all areas which we should always look at on bone X-ray. Okay, and another query which was on the trapped periosteum. So this is an image where you can see that there is trapped periosteum here between the growth plate. There is widening of the physis and irregularity. So this is called a trapped periosteum with Salter-Harris fracture. Last case diagnosis is dermatofibrosarcoma protuberans. It's a skin and neck cell malignant lesion. So someone has asked me for the last case diagnosis. I think I've discussed all the Q&As.
Yeah, I know, Gaurav. Thank you so much for your time and as always, patient teaching and amazing cases. Thank you so much.
Thank you, Ankita. Thank you, everyone, for your attention. Bye-bye.
Bye, everyone. Good night.
Record.